I'm just looking at this backdrop shared here. It's not just me who's who's aged since this photograph, which is comforting.
This is exactly what I was thinking, Vishal. All looking so much younger.
Pre-COVID.
Yeah. Thank God for the photographs.
Okay, looks like we are at 8:30, our start time. We have people trickling in. Why don't we give it just another 30 seconds and then we will begin. Okay, why don't we get started? We do have a lot of ground to cover. I think we're expecting just upwards of maybe 50 or so people, and or maybe a little bit more, and we're sort of inching our way there. So people can trickle in as we go through our intro comments. So welcome everyone. Welcome to our collaborative learning sessions as part of Dasra's COVID relief campaign, which we're calling Back the Front Line. We're expecting, like I said, 50 to 60 people in our session today. Like many of you know, Dasra is doing a series of webinars, and this one in particular, like a few we've done in the past and many that we will do in the future, are geared towards, a global audience, and largely, individuals and others based in the US and the UK. And so, a good evening for those of us in India, and good morning and perhaps a good afternoon to the rest of you, and maybe a few other time zones as well. We're expecting about, just to give us a sense of who's in the room, who's here. We have about half the, RSVPs were from primarily a philanthropic audience, so funders, individuals, foundations, some corporates. We have about 30% of our group here that will be nonprofit organizations, from India, but of course from other geographies as well. And the remaining sort of 15 to 20% being experts, academics, peer organizations, intermediaries, and so on. We would like to, of course, thank all of you for standing with us, with our campaign during this time, of immense and urgent need for India. With your support, we've come a long way since launching this campaign in late April, with just 5 organizations and a relatively small online fundraiser. We've since raised a little over $8 million that we aim to disperse to over 100 nonprofit organizations, and have already deployed over 3 million to almost 50 nonprofit organizations. These organizations, and you will hear from them very shortly, are really serving the most marginalized groups in India, from hard to reach communities geographically to, marginalized groups like tribal communities, marginalized Muslim communities, single women households, at-risk children, marginalized farmers, migrants and informal workers, daily wage laborers. And the campaign and the work through our partners, our nonprofit partners, is really around providing them with access to the basics, right? Daily meals, home care kits, mental health services, financial assistance, and much, much more. Back the Frontline spans the entire country. And as we engage with groups across the country, it's becoming pretty clear to us that, unlike periods last year, when the whole world in some ways was almost in the same boat, and, unlike early April, when all of India seemed to be in the same situation, that same sort of, terrible state, now certain geographies, certain groups are still in that state, have been left sort of in that state, while the rest of us, are not, and have sort of moved on. And this relationship with COVID seems to be, not as shared anymore. And we don't see the images of burning pyres any longer. But at Dasra, we're fully conscious there's a lot more to be done, both in terms of relief and preparation for the third wave, but also in terms of longer term development, right? We've read the statistics. Most of us have, only 4% of the country is fully vaccinated. There's a significant amount of vaccine hesitancy in the country, in large parts, especially in rural parts of the country. The capacity and safety of frontline workers in rural areas is extremely low. Healthcare systems have been insufficiently bolstered in urban centers, and it's much worse in rural areas. And that was sort of the part of the lockdown, the point of the lockdown in any case, right? To buy us time to strengthen systems, and even as we slowly inch our way towards the third wave, we're seeing that perhaps that hasn't happened quite as well as we would like to see. And there's, of course, a longer term impact on development that we have to contend with, right? Studies indicate that approximately 230 million people in India fell into poverty in 2020 because of the economic repercussions of COVID-19. Shrinking incomes have led to food insecurity and a nutrition crisis, especially in rural India. School closures and lack of access to learning is leading to an impending education crisis. And so I say that, because for us at Dasra and for Back the Frontline, for our Back the Frontline campaign, we're really pushing ourselves to not just reach the most underserved, but we're also strapping in for the long-term support to these, organizations at the frontline, and to be able to eventually move from relief, to rebuilding and, towards resilience of, first and foremost, their own organizations, but also the sector at large. And this journey that we're on, right, from extended relief and then rebuilding and resilience, we're doing these webinars, and the whole idea is to share this journey with all of you, with our supporters, present and new. And we certainly would like to count on your continued support, and hopefully, as the session makes clear, there's so much still left to be done. Now, of course, none of this would be possible without, these fantastic organizations and leaders who are so close, where there's so much proximity to issues on the ground. And so we have an hour together, all of us, or just about, I guess, 53 minutes. I see that I am already overspending my time allocation. So I'll go on for another 5 seconds just to say, we're gonna go into a facilitated panel conversation, leave time for question and answers, and then close, in the 1 hour that we had allocated. I'll now hand over to my colleague Sonvi, who works closely with these groups to facilitate this discussion. And some of you may have also had a chance to hear our webinar last week, which we facilitated, that focus on domestic philanthropy in India and nonprofits who can't access foreign funding. So this is very much a series of conversations that we're having, and we're very happy that you could join us today. And with that, Sonvi, over to you.
Thanks, Vishal. Thank you for the introduction. Good evening, everybody, and thank you for making it today to our webinar. As Vishal mentioned, this is a journey that Dasra has gotten onto, and I think it's important for us to share a few interesting aspects around it that you may value as well. In the history of the country, in all development aspects, global philanthropy has usually had a cutting-edge role to play, just by means of taking more risks, setting in new trends, by way of which new kind of work could emanate in the country, new kind of interventions could emanate in the country. And through Back the Frontline, Dasra has been able to go beyond its network of usual organizations to the back of the beyond, to the more marginalized, to the groups and the organizations that are not so well known in the mainstream. And we are going to use this opportunity and this exposure to learn more, increase our knowledge on what are the perils that these communities that we don't even know, don't even understand, go through and have gone through in the period of COVID. But we also want to extend that exposure and that possibility to learn about, the lesser known India through this experience. So with that, I in fact will not take too much time, but my speakers are going to tell you what I really mean. My first speaker, of course, today is Dr. Pavitra Mohan, who has co-founded Basic Healthcare Services, which is a non-profit that's working in Rajasthan and Gujarat to provide high quality, low cost primary healthcare services to the most underprivileged populations. Dr. Pavitra, thank you for joining us today. I just wanted to open by asking you, if you could tell us a little bit about the unique challenges that were faced by the communities you served during the COVID period, and how did your organization respond to them? That would be my, yeah.
Uh, Thanks for inviting us here, Suvi. And we work in South Rajasthan in areas which are rural, predominantly inhabited by tribal communities, and a very large proportion of young men move out of these areas to work in cities as laborers, as labor migrants. Uh, Leaving behind the families, and the reason why they migrate is because the land sizes are extremely small and there is very little local livelihood. uh, last year, when the lockdown was announced, many of the young men were in cities and they started migrating back, and we saw all these pictures of men walking back. We were receiving them at this end while when they were coming back, traveling hundreds of kilometers, broken and bruised and sometimes beaten on the way. Their families back here were, of course, extremely terrified, and there was a sudden loss of wages, and access to any form of healthcare was disrupted because there was a complete lockdown. People could not travel, they didn't have enough money, and there was hunger, and there wasn't much of COVID infection at that time. When people came back, there was a very slight surge, but that was more of a ripple which lasted for a month or so, but very few people got infected. We were looking at very closely in the areas that we work in. But what happened was, because of the shortage of food, loss of wages, and inability to access healthcare, there was an increase in there was significant increase in other illnesses, like they could not access treatment for tuberculosis. A lot of people, the treatment was disrupted. Women could not go and deliver in hospitals because either they were not able to reach there, or even if they reached there, the government facilities were focusing only on COVID and not providing any other service. We also saw a significant increase in child malnutrition levels during that time, almost 20% increase in the areas that we work in as a result. And therefore, our focus was at that time to continue to provide uninterrupted health services, reach out to the most vulnerable, provide nutrition support. We run a network of daycare centers which had to be closed because of the risk of transmission, but we continued to provide hot cooked meals at the household level, which was extremely helpful. We realized that was the only kind of source of food for those families. And the reason that we were open 24/7 meant that our workload actually increased when most other hospitals and health centers were closed during that period. This year, in contrast, what started off was initially insidious, but then very rapidly increasing transmission of the virus across the rural areas that we work in, starting from the smaller towns to larger villages, to smaller villages, then to deeper and the deepest hamlets. So no one was really spared this time. And because of the fact that last time people were especially those from migrant families were returning, were treated so shabbily by the communities, by the public system, there was a huge distrust. And therefore, even when they were infected, they were unwilling to come out and seek care. Or even when somebody was reaching them, they had a lot of fear that they would again be isolated, quarantined, forcefully evacuated, etc. And that led to a situation where there were a lot of people who were unwell, but there was no way to reach. And that's where we then started a home care program to reach out through our large network of community volunteers to households to provide home care, to provide medication, and to provide referral care where required. There was also, unlike in cities where you saw all those burning pyres and, the hospitals being overcrowded and so on, in rural areas, it didn't happen because people were either dying at home. They just did not have access to the hospitals, right? There were, of course, some places, some district hospitals where the closer by people did reach and they led to overloading. But primarily, people were not able to access healthcare or did not want to access care outside home because of the fears and distress. And many people, therefore, were dying at home. And that's where the home care became important. And also rebuilding some trust with the communities, that if you are unwell and you do not get better with home care, you would require a hospitalized care. So on the other hand, we were helping the health systems to be strengthened, setting up COVID care centers at the block headquarters so that it's not in the city. You don't have to travel 100 kilometers, but maybe 20, 30 kilometers, which is still closer by, which is not crowded, ensured that oxygen was available there, and the set of skills. So which is, this continued for around 4 weeks, and then of course the transmission has started receding. The fear of, but that fear and distress continued, and which is affecting the vaccination and acceptance of vaccination in these communities. And I think a huge challenge is to address that, because it is not only because of myths or misconceptions, which is there everywhere. It is also because of this fear of the system, that there is such a distress that they say that it is a vaccine or it's an injection that kills. So just imagining the degree of distress between the public system and communities, that people feel that it is something that might that is to kill people and not to really prevent that. So right now, I think a huge challenge is to reclaim that trust, and also strengthen the systems to be able to manage any subsequent wave or ripple or whatever it would be. We will see. But the systems were found wanting at this point of time, and next time we would not have any excuse not to have been better prepared than we were at this time.
Yeah.
So I'll just stop here for the time being.
No, thank you, Dr. Pavitra. That's really useful. So a lot of what I'm hearing is there was a whole trust deficit that, of course, your organization and others like yours had to come in to kind of bridge. And I think that role is going to be critical, not only for the next few months, but I think for years to come, as there's no room but for that interface between the communities and the system that provides healthcare and access to preventive measures, right? Murariji, I'll move on to you. Murariji, let me just introduce you first. Murari Chaudhary is a founding member of NEEDS, and he's taking us today to Bihar and Jharkhand, where he works with some of the most vulnerable poverty-stricken communities. NEEDS also has a huge gender lens that they deploy to most of their work. Thank you for joining us today, Murariji.
Thank you.
From a segment that was quite covered for the first time, of course, but yet covered last year, which was the whole returning migrant community, coming to areas which the media does not cover at all. Could you tell us a little bit about the communities you work for and their COVID situation and your response to that as an organization?
Thank you, Sonvi. Jharkhand is one of the known tribal state, and it's known for where the drum beats silently. Most of the region that we work are over 60-65% tribal dominated blocks. And it's popularly known as media dark because the information does not go in or it does not come out. So if we talk about the construction of roads, etc., recently has really improved. So communication at that way has improved, but the information technology is missing. Now, when the government started talking about vaccination, registration for vaccination, etc., it's using the IT, which is actually the Wi-Fi connectivity. The smartphone availability is less than 2% in rural areas. So we could see the lot of ambulance running around the city and town, but what is happening in the rural corners are really serious. There are 26,000 deaths were reported from the rural area, and believe or not, none of them were reported as COVID deaths. So these are one of the challenges, that how do we really reach out to the community, because there's an absolute lack of health facilities in rural areas. So people don't have a trust that even if I say that I have this problem, where do I go? So that is one area. Secondly, when you talk about vaccine is free, available, and Jharkhand rarely had a crisis of vaccine, but takers are very less. There are huge rumors at community level, and that only can be solved through interpersonal communication, reaching out to the community in their language, engaging women because they are one kind of influencer. And at the same time, how do we really engage religious leaders, tribal leaders, opinion makers, school teachers, and their reach out. So these are the challenge where you need to be there physically. It's not that you do some announcement and broadcasting. It really is not reaching them. So that's another area of concern. Second, the biggest thing that we see is a huge malnutrition and anemia, which is already was there. Now it is severe because food supplies are disrupted, availability, because the entire livelihood has been impacted, and farming was always open, but even the farmers, as they come up with the products, they don't have a market for it because of the impact. Almost 45% people here, they do a seasonal migration. So that is completely affected. 40% population is below poverty line. Mostly they are reliant on the wage labor, which is fully disrupted. Wages are not available. MGNREGA is supposed to do this crisis management, but again, the MGNREGA, if you see the percentage of uptake of MGNREGA is extremely low during these last 3 months, because people had a fear. They don't want to go out and engage into the job. Last time,
sorry, you may want to explain what NREGA is.
Actually, it's an employment guarantee program by the government. It's not a program, it's a law which provides a guarantee for 100 days employment in a year to a family. So the people who are engaged in a wage labor can get engaged here and earn wage. And 100, so approximately annually, you earn 6,000 rupees if one family earns for entire 100 days. So that itself is a little crisis management program. But that uptake is, again, is a huge low because people did not come to work for NREG program. Government is trying to, that's other issue is, as Dr. Pavitra already mentioned, Jharkhand is, I think, one stage ahead on that in terms of rumors related to vaccination. So people don't want to take vaccine. And you need to really do an interpersonal communication, engage religious leader to work on that. And wherever we were able to do that, I think there's a results we can see, but it's very human intensive. You need to really put a lot of efforts. Other distress that we see is a pregnant woman. So already we have early marriage, early pregnancies. So they are already in a problem. Now, entire health system is engaged into vaccination and other COVID management programs. So there's RS services are hugely disrupted. Nutrition supplement access is hugely low. So that is creating another problems which probably have a long-term impact in the community. So that is one area that purposefully need to look at. So these are, and then if you see these wage laborers, so they are in the food crisis, they're in the nutrition crisis. RS services, as I said, is already disrupted. So that they require a kind of a confidence building, at the same time, some kind of a doorstep services. If we talk about this, ASA workers are supposed to provide the doorstep services, but they are basically linked. ASA workers are a link to a system, health facility. And ANMs are trained to provide services. But there's in 5,000 to 6,000 population, there's one ANM, and they are now fully engaged into vaccination. So these are, again, real problems. How to reach areas in terms of not the road, but in terms of reaching out to the community in a far area, providing them, reaching out with the vaccine packages. So those are, again, issues. And good thing is that government is listening to us. So government has agreed that, okay, we'll provide mobile vans, the camps will be done in the remote areas, provided that we have a good mobilization there for the uptake. But again, I say that requires a lot of engagement. So that is one area that which requires a lot of attention.
Absolutely. Thank you, Murariji. I think very valuable. And the point that you make about reaching far-flung areas, not by roads, but as a system, as a country, actually is a great segue to you, Sujata. We can't go any further than Ladakh now, can we? Take us to Ladakh, Sujata, and let me just introduce you and your organization. Sujata Sahu is the founder of 17,000 Feet. This is an organization, true to its name, that is working in the remote and mountainous villages across Ladakh on strengthening the system on a whole bunch of fronts. Sujata, your organization was engaged deeply in providing respect to those who are the first respondents in a region that has nobody. Just help us understand what life was like in the COVID scenario for your community.
Sure. Is my audio okay?
Yes, very
Can
good.
you guys hear me? Perfect. Awesome. Hi, all. Thank you for having me, and thank you for this entire community of supporters that's making our work so much more possible. So before I get into this, I think a little bit of background about Ladakh is necessary. It's unlike any other region that you've ever heard of or seen. So while Murari ji talked about remote areas, Dr. Parth also talked about remote areas. Ladakh is a high altitude mountainous cold desert. So we're talking of an area of about 60,000 square kilometers of sheer high altitude terrain, 9,000 feet and above. This is where oxygen supply is low. There are no roads, and in these areas we have about 1,000 hamlets. Now, just imagine an area of 60,000 square kilometers having a population of barely 300,000 people. That's like talking about 5 people to 1 square kilometer. That's how sparsely populated it is. This entire 60,000 square kilometers is filled with about 1,000 hamlets. So the average size of a hamlet is just maybe 100 homes, maybe 50 homes. And these hamlets are spread so far apart. Most of these hamlets don't have electricity. They don't have mobile connectivity. I'm talking of basic 2G. Many of them do not have access to roads. Reaching many of them actually require crossing mountainous passes for 1, 2, maybe 3 days to reach. This is the kind of terrain that 17,000 feet operates in. So largely what has happened during COVID, so now Ladakh being a high altitude desert, it depends entirely on the rest of the country for a lot of basic supplies. Nothing grows in this cold desert. There are very few things that grow. So starting from whether it's your rice, your pulses, your medicinal items, anything comes from outside. So for Ladakh to even survive on it, so they're a very resilient people, but for Ladakh to survive on its own, they need everything from say Delhi or Chandigarh and things which are either brought in by road or they're brought in by flight. And the problem with this is when the local administration, the Ladakh government has been struggling all this time, not just for COVID, I mean, in general, ensuring that all of the citizens get the care and get the infrastructure and get the support they need. But being that it is so spread so far apart and there is no way to reach them, that has been the crux of the issue for the government for a very long time. And that's what 17,000 feet does best, is try to reach the remotest village. Doesn't matter if it's a 3-day walk or a 3-day climb. That's where 17,000 feet reaches. Now, last year when COVID hit, we work largely with government schools and preschool centers to improve education in the remotest of areas. And in doing so, in every village, just to give you another sense, these villages have just a few homes, a place of worship, which is either a mosque or a Buddhist monastery, and they have a school. There is absolutely nothing else. There may be a very tiny sub-primary health center, which has absolutely nothing. There are no beds. There barely any doctors. They're just the basic medicines available. Last year when COVID struck, the first way that the government responded was by shutting down access into Ladakh, which is a logical thing to do. There are just 2 roads that come into Ladakh. But when you shut access down to Ladakh, that means shutting down of supplies, shutting down of basic necessities into the remote villages. And that became a huge problem because opening up the roads instantly increased the number of cases. Last year, we had about 25 to 30,000 Ladakhis who were stranded outside Ladakh, and they had to be brought back in for the entire lockdown. The minute we brought them back in, the cases rose exponentially, and it got really bad in the remote villages. Now, the problem with this is the primary healthcare centers are not equipped to handle any kind of emergencies at all. Just to give you a sense, we are talking about just basically 6 hospitals covering 60,000 square kilometers. You do the math. There's barely any this thing. And the health centers, there are few large health centers, but they do not cover the remote villages at all. For even today, for basic medical supplies in the remote villages, people make up makeshift stretchers. They put people on there. They walk for a few hours to reach the main road, and then wait for some place where they can get telephone connectivity to ask someone. People are airlifted by the Indian Air Force or the Indian Army for medical emergencies. In places like these, when you shut these things down, not only do they not have access to supplies, they don't have access to medical equipment. Last year, 17,000 feet, what we did, because our presence in the remote villages is so heavy. We work in about 25% of the villages across the region. So while the government did its best to stop the supplies and stop the entry of the virus, what we did was we showed up all of our villages with the supplies that they needed. So this to prevent an outbreak. Ladakh cannot handle an outbreak. Our healthcare infrastructure is too weak. So last year we went in by actually starting with our school systems, through them to actually reach basic sanitizers and cleaning equipment. You don't get any of these things in the villages. They have to come down to the main town, which could take them a day or two. Right. So we did that in across 230 villages, and then counsel them to keep children at home. They were trying to get to the schools because they've been out of schools for a very long time. So we also went to started our own, taking the tablet homes, that we sent children home and told them, keep your children. A lot of counseling was needed. They didn't have access to information at all. Right. This year, what is happening, and while the government in the last 1 year, I'm very happy to say that the one thing is they are trying to shore up on the main healthcare centers, which is in the main 2-3 towns. Yeah. But while they have taken care of that, our remote villages, and again, like Dr. Murari also said, that the door-to-door job, reaching the last village, the last mile, is the job of the ASHA worker or the Anganwadi worker. And these guys are not equipped. Not only are they not equipped, they're not trained. So we're today reaching out to about 500 of these Anganwadi workers, just to equip them with everything, a simple oximeter, a simple thermometer. Households don't even have thermometers in their homes. There's no way to buy this from. So we're supporting them. So they go door to door and talk to the people about how best to take care of themselves, not to say, okay, go, you're sick, go to the hospital. There are 500 beds for an entire population of Ladakh, and that's it. So we're supporting our Anganwadi workers to go door to door to ensure that they're equipped with what they need. They're able to detect and prevent, and counsel the villagers to say, go to the hospitals only if it's absolutely necessary, and escalate when necessary. Yeah. So while the government is looking at the main hospitals, we are looking at ensuring that they don't get flooded. And because largely, if you look at all of it, a lot of COVID symptoms are treated in home. Yeah. Only if you're able to tell that you don't have any comorbidity, if your oxygen levels are not low. So those are the things that we are helping them with.
Thank you, Sujata. And thank you all the speakers. I think we just spoke about what survival meant for some of these most remote and marginalized and underprivileged communities this year. Dr. Pavitra, if I come to the future a little bit and not the very distant future, what's keeping you up at night for the communities you work for as we think about the settling down a little bit or going into the next wave? And what's keeping you up about the next 6 to 8 months?
So, there are two major issues right now and concerns, let me say. One is about the whole issue of vaccination and the huge distress because of which there is an alienation and decreased uptake and demand for vaccination at the moment for the reasons that I mentioned earlier. So, how do we really, while building the trust, also promote vaccination in a reasonable time? Because we don't have much time. If we are not able to vaccinate a sufficient proportion of population over the next 4 to 6 months, there would be the next wave is going to be much larger. At the same time, you can't force it because there are valid concerns and the trust needs time to build that up. So I think that is one huge challenge, and that's where we are kind of using a lot of our energies in reaching out to the communities, talking to them, talking to all the different players on the ground. And doing some honest communication about the disease, about the transmission, about the next wave, etc.
Sure.
Talking to a lot of the tribal leaders, etc. to ensure that there is a greater understanding and a greater trust building. On the other hand, simultaneously, the issue is that, as I said, that in the first wave, there were in the first two waves, there was a relatively much lesser preparedness of the health systems, and that has not significantly changed. While it did try to gear up towards the end of the second wave, uh, how do we really work with the healthcare systems to build their capacity to manage it much better this time in a more decentralized manner, right? So that the hospitals and you really need to provide care which is closer home, and therefore strengthening the primary health centers and community health centers which are closer home, and building their capacity. The third, which is, I mean, I'm just kind of right now we're dealing with a situation where there was a adverse effect of a vaccination, which is known, right? Though it is rare, but there, and any one such incident can really roll back a lot of what we have gained in last 1 or 2 months, by way of reaching out to communities, assuring them that it is safe. So, how do you deal with the post-vaccination issues is a huge challenge, which we are under playing right now. Right now there's a person whom we are trying to manage after and the systems are often not prepared for that, right? Because especially the rural healthcare systems. So I think these are two major challenges. One is to strengthen the health systems, and second is to promote vaccination while dealing with all the possible issues that can roll back the gains in time.
Right. And philanthropy has a significant role to play, I think, in supporting organizations like yourself to do that.
Absolutely. I think, I mean, the communities on the ground ultimately require, I mean, you need to reach out to them, and that's where I think a lot of support is required.
Absolutely. Murariji, one is health, right? But what does the livelihood scene look like? I mean, what's keeping you up at night? Once this subsides, what will be left? What are some of the communities that have been most delinked? I know you work closely with the farmer communities and many others. Just tell us a little bit about what the future looks like, what will be needed.
Yeah, I think there's a need for a COVID preparedness in terms of livelihood resilience creating, because we need to also see in consultation with the farmers that the kind of challenges that they are facing, and also the people who are in a wage labor engagement. So they are the most vulnerable, the small and marginal farmers and the wage laborer. And the resilience could be because we need to also give a feedback to the government with some real database of the remote areas that actually what kind of crisis is happening. So we need to generate those kind of information and help government also to redesign certain their programs like MGNRG, etc. But at the same time, how do we really see that as a kind of a disaster preparedness program that we do for other kind of a disaster for COVID? And there we need to see that crisis management above the crisis management, because the crisis management is some kind of a instant support to them for a time being. But at the same time, if the small and marginal farmers are producing something, they're able to do that. How do we really create a value chain intervention in terms of market linkages, link them with a little broader market and etc. So that kind of intervention will save the small and marginal farmers. And for wage laborer, is some kind of a support they require for the time being when the crisis is there. And then we need to see that how they can really engage in various other kind of an activity. And for examples, if some agriculture activities are going on, and then how do we create a space for this reverse migrant or the seasonally migrant people who used to go for 3 months, 6 months locally, create agriculture activities a little larger than what was normally happening, so that they get engaged locally within the community and villages. And what a government engagement could be like, how do we a little remodify MGNRIG programs to really supplement that process? So that is what we think. We are thinking very deeply in terms of livelihood resilience.
Right. So the role of philanthropy would really be to be helping you build
Very
some of these bridges back towards livelihoods. And what is the horizon, Murariji? I mean, when are you expecting how long will this volatility, this broken kind of
we are expecting another 7 to 8 months, or approximately 9 months, because you see the livelihood crisis would have a long-term impact. If this monsoon they are unable to do something, if they are not engaged, so that will really roll out, because we don't have an irrigation system. So agriculture is reliant on monsoon, which is already on. So if they fail this monsoon to have a good product and have a market linkages, then the next 1 year for the next monsoon, they will be having an impact. So actually it's a 9 months to 1 year, a kind of a support this family is required to come up with some mechanism where they can really reduce their impact on malnutrition, reduce their impacts of food crisis, food insecurity, etc.
Sure, thank you. I just want to reiterate that India is kind of preparing to protect its children the most as the third wave hits the country. It's a very harsh fact. We're all wishing it away. But malnutrition is one of the biggest reasons that the country is worried. And so a lot of attention is needed, not only in the short run, but in the long run to protect our children, because vaccines haven't saturated the way they should have. And so it's a bit scary, it's a bit disturbing, but that is a reality that India is facing at the moment. So, Sujata, just moving on to you. I mean, I was just sharing what keeps me up at night, but what is keeping you up at night? And what is the, not just the 6 to 8 months, but what is life going to look like beyond this? I mean, you work in education. Are we where we were? How are the standards? Have we backslided? What's going on? You're on mute, Sujata.
Yes, definitely keeping me up at night, Sonvi, for sure. So, the Ladakh education system, we have a very short window. We barely study for 8 months, our children, because of very, very severe winters of minus 50 degrees. Kids in Ladakh have not gone to school. 70 to 80% have not been learning since November 2019. That's the last time the schools were opened, and they haven't opened since. If they opened, it's just been for a month or two. In terms of learning outcomes, there was already a huge crisis. And what has happened is, in the remote villages, parents only depend on government schools. There is nothing else. When a school has 15 children or 5 children, there is very unlikely that you'll find a private school there. So when there's such a large dependency on the government school, and schools have been closed, and with the government school education system not being up to the best quality, children have slid down way beyond what should be there. It is true all across the country, but what has been severely worse for Ladakh is our lack of access to network. 70% of our villages do not have basic mobile connectivity, so it's been impossible for these children to study. There has been nothing going on. Just the 30% who live in the main towns were able to access online education. And for us, we've been doing our stuff door to door, going to schools, going to villages, counseling them, talking to them about stuff. And in the few villages where we developed a very unique, specialized offline learning solution. So in our villages, in 100-odd villages where this learning solution is up and ready, those children were able to benefit. But what about the remaining? And this is a huge crisis, and infrastructure, getting mobile network is not an easy job. It is something, it's an institutional failure. And that is a crisis. And currently, unfortunately, Ladakh is not the only one. A lot of the smaller Himalayan states in the entire northeastern belt, we have about 11 states, Sikkim and Arunachal, Manipur, majority of the regions are not covered by network. How are these children ever going to come back to where they are at? So that's basically what it is. So we're trying to work with the government to find alternate solutions. How do we bridge this gap? India made such progress when it came to, access to education. We've just slid back so much. And with this reverse migration that's happening, a lot of children are now gone back to their villages and have been there for many months. Our tiny little government schools are not even equipped to take care of now. Enrollment's now doubled in the government schools, and we don't have enough teachers. It's back to the drawing boards on me. So yes, that's basically it. And also, like I said, the other thing is we also work a lot to drive tourism into remote villages to increase livelihood options. Now that's been dead for 2 years now. This is the second year that Ladakh has taken a hit on tourism. So we'll have to find a way in which to encourage. Ladakh depends almost entirely on tourism for its economy. Finding ways to get that back into Ladakh. That's what keeps me up.
Thank you,
Yeah,
Sujata.
so it's
We have, in fact, a question from the audience, which perhaps we could take up. What are the gender disparities that COVID has brought out in your communities? And it's open, any of you can take it. Murari ji, I know you work very closely on the gender issue. What have been the experiences on supporting women, especially in the rural and backward areas?
Yeah, actually, what we started looking at that, what is the impact among adolescent groups, what is the impact on pregnant women, young pregnancies, and we found there's a lot of distress, mental distress, even among the children who are unable to mingle with other children, not going to schools, and in a rural area, you know, there's no much opportunities for any activities. And when government talk about these Digi programs, that is mobile-based education, which is actually not happening because they don't have a Wi-Fi connectivity. As I said, it's only 2%. So though there's a mental distress, there's an issues of RH activities are completely, reproductive health related activities are fully disrupted. Ordinary, like there's a pad poverty, people are not ready to invest because whatever small money they get in the crisis period, so they see that what are the things which can be saved from the women's investment. So, and women are also like motivated like that. If they have small money, they invest on children and their husbands. So they don't want to invest on themselves. So these are the kind of a crisis that we see. And the supply mechanism also is, people are not focusing actually. That these are the issues that need to be focused. So even the supplies are there, but who is going to support? Who is going to distribute? There are a lot of issues at that level because then everything now it talks about is a COVID vaccination, and so engagements are like that. So these things are completely the perspective of gender, perspective issues related to women are absolutely, and when you have more men coming into the house, so there's a crisis, there's of privacy, and there's also pressure on women to do more work because now you have to serve those. And during this COVID period, when we see that a lot of men are staying at home, so pressure on women are going up, and there are also resulting into domestic violence. So these are a lot of issues that we see, and we tried to engage a lot of adolescent girl champions, etc., to do some reach out activities to whatever way they can. And we are talking to a lot of women we know. We created a WhatsApp group also for those who has some kind of an access. So we actually spent some money on 60 smartphones to help this kind of a leaders to link with a larger number of groups. And there are, we also see the access to technology by health workers, Anganwadi workers, ASA workers. So we try to reach out through them largely, but recently what we started doing is how we have deputed almost 20 to 30 people at each sub-districts where we operate to reach out to the community and see that how we. So primarily currently what we are doing is to help in confidence building. And they should not feel that. So we release some helplines and say if no phone rings, our helpline will ring. So you just let us know, our people will reach out and come up with some solutions. So that is the way currently we are looking at things.
No, very valuable. So it takes an extra effort to ensure that the woman is protected, safe. And is there also a discrepancy in health-seeking behavior, Dr. Mohan?
So, Sunil, what we saw was a huge increase in domestic violence in our areas because there are unemployed, battered young men who have no job to do and they're now at home. So we were seeing in our clinics a significant increase in cases with violence, with physical violence. And we also saw a huge increase in the need for contraception and for safe abortion. So while our clinics could provide that because we were closer to where people lived, and we were continuing to provide those services. But in many other places, that led to a significant increase in the incidence of unsafe abortions or teenage pregnancies, unwanted pregnancies, where they had no other choice but to be carry on. And So the third was we're seeing a huge increase in home births because women are just not able, either because of lack of money or lack of transport. Women are not able to reach hospitals or the nearest health center, which in many cases is largely focused on COVID and not really providing the whole basket of services. So I think in terms of health, there has been a huge, the women have been more hit. Uh,
Yeah.
on the other hand, I also have a great experience of working with women. There was some question about how do you work with women. I was just recollecting of, we were going home to identify people suffering from COVID and, provide medication and advice for home isolation. And we saw this woman who runs a small shop in a very, very remote hamlet. And, and she herself was suffering from COVID. We found out that she had symptoms of COVID. And so we advised her, gave her medication. And then she went around and brought 3 more women from her own area and said, look, she's also suffering from, you can't imagine that from a man, that, if at all, he'll be bothered only about himself. Now, this woman who, despite being ill herself, was really bothered about women in her neighborhood, and she brought them all to stay. So it was such a gratifying thing that while on the one hand there is a suffering, but they also have a huge value in addressing the additional vulnerabilities that are happening in their community. So yeah, it's a huge
Thank you.
working with them.
Yeah, thank you. And Sujata, there's a question also around whether or not schools should reopen, and what are we possibly going to be able to do to protect our children in the third wave? Any thoughts?
Yeah, I read the question, interesting question. So here's, it's going to take a while, I think, before as a country we can say we're safe to open schools again. It's a liability, it's something, a decision.
Sujata, we lost you. I think your connectivity.
I will say, let's just take a case of Ladakh, for example. I have schools which have 15 children, 5 children, 25 children. If there are ways in which we can ensure that the village is self-sustained and we shut down access to these villages, yes, these schools can be opened. But it's a complete case-to-case basis. It depends on a very district or even a block level administration. If we can decentralize decision-making to that level, I think there is a possibility. In fact, at Ladakh, we were thinking about it, that yes, I think children can be relatively safe. In Ladakh, the distances are quite, very distant from each other. One village to another could take 3 to 4 hours. So yes, I think that is there. And then the second thing I think is government has released a lot of guidelines on how communities can support home-based education. That's easier said than done. Majority of the communities we all work with are, they're not adequately educated. Many of them are illiterate. So that is a problem. But I think nonprofits working in the areas can support the government in kind of running pilot programs and helping to scale. I think the need of the hour right here is to help the government. In the sense, this is unprecedented for all of us. And I think a lot of us nonprofits we work in certain number.
Sujata, we lost you again.
Percent of the school programs. So I believe, yes, they can be opened. I believe the rules cannot be one for the entire country or even for the entire state.
Yeah.
There is possibilities, and I think we should work with this.
Yeah.
We should be able to work with this and get communities into this as well. Yeah.
Absolutely. Absolutely. Murariji, I think you wanted to say something.
Just wanted to add,
Yeah.
like there are a lot of, other day we were having a meeting with our team, and we see there are a lot of ANMs who are waiting for an appointment. So they are actually trained. And in terms of preparedness, if such cadres can be really trained and skilled in terms of how do you care children and the pregnant women, those who are in crisis, and such cadre can later on will be highly skilled people which get placement in the government. But at this time of crisis, a group of cadre can be really engaged with the community and to help this kind of management, crisis management. So I just wanted to add that.
Absolutely. Thank you so much. And with that, perhaps I should hand it over to Vishal to take us to the culmination of this session. Thank you, everybody. Thank you for your insights. Very valuable.
Yeah, thank you. Thanks, Onvi. Thank you, Pavitra, Sujata, and Murariji. Yeah, I mean, it's going back to sort of where we started. I think hearing your insights, the timelines, for how long we think this will continue, what's keeping you all up at night. I think it's not entirely shocking, but clearly sort of a sad realization that while we've come, a long way, there's still, we've come far enough to know how much further we need to go, right? And one thing we do want to leave the audience with here, especially those of you joining us from abroad and overseas, where it might feel like things have returned back to normal, and at least that's what you might feel and touch and feel and see locally. It's quite evident that back here in India, and especially in some of the areas that these organizations and the communities they serve, we're still in the thick of a lot of these issues, and are also grappling with the long-term implications of what COVID means for so many of our other outcomes that in some ways have almost been rendered fragile, right? Or potentially at risk of backsliding. Uh, for Dasra and for the Back the Frontline initiative, our campaign, we do believe that we are in, these are unprecedented times in many ways, and this moment does call for a new kind of philanthropy that's nurtures and supports these locally led groups and leaders like we just heard in this session. And there's a real need to rethink and rebuild a much more inclusive India, because vulnerabilities are high, and external shocks have the swift ability to move us back again, right? Decades, if not more than that, which is pretty incredible. Uh, and we do recognize that philanthropy alone cannot solve some of these deeply entrenched discrimination and inequities that we've heard about. There's a clear need to stand in solidarity, and support local partners like these, with the opportunities to exercise power, agency, leadership, and the financial support to do what they're doing with their local knowledge, with their local understanding of what communities really need. And so, our ask for all of you all today is to stay engaged. We have more webinars coming up. We have a website called backthefrontline.dasra.org that we'll be sharing in our also in our summary, which highlights a lot of the work that's going on. We'll have snippets of these and all of our other webinars, and really should become it is a place we believe where you can grasp sort of the overall situation, right, in its totality, but also get a sense of what some of these groups are doing to really move the needle in both the short and the long term. And we continue to actively raise support for this campaign and for organizations just like these. And if nothing else, we hope today is a reminder that we're in this for the long term. We're in this for the long haul, and we do sincerely hope that you will continue to stand up and join hands with us as we try and do our best to address this significant predicament that we're in. And so with that, I just see that we're actually ending 2 minutes before time, which I think might be a record for me, certainly, if not for us with our webinars. So thank you to our speakers. Sombi, thank you so much to our moderator, and thank you to our audience from dialing in from all over the world. And we look forward to connecting with you again.
Thank you.
Thank you.
Thank you so much.
Thank you, Murariji.